Good morning, everyone. I think we're going to get going. I hope you had a great weekend. We are starting the webcast now. My name is Josh Sharfstein. I'm the Vice Dean for Public Health Practice and Community Engagement here at the Johns Hopkins Bloomberg School of Public Health. And we're really excited for this class in the Public Health Policy class with special guests, Karen DeSalvo and Dean Ellen MacKenzie. So let me give you the basic run through of the plan, and then I'm going to do a brief introduction of Dr. DeSalvo, and then she's going to get things kicked off. So we've got this class in 3 sections. The first is Dr. DeSalvo is going to give a talk on Public Health 3.0. The second is Dean MacKenzie is going to interview Dr. DeSalvo and take questions from the audience. And then at 10:30, we are having the Twitter chat using the hashtag PopHealthRT on the key questions facing the field of population health. And we're looking forward to you all participating as well as people watching on the webcast. So it is really my great pleasure to introduce Dr. Karen DeSalvo. Let me just tell you a little bit about her background. She is a general internist who worked at Tulane, including as the Vice Dean for Community Affairs there. She, in 2011, became the Health Commissioner of New Orleans. So she has both academic experience and significant experience in public health practice. In 2014, she joined the Obama administration as the National Coordinator for Health IT. So she went from the front lines of public health practice to being responsible for a lot of critical policies related to health IT in medicine and beyond. That's when I really got a chance to meet her and see her bring a public health sensibility to topics that can get quite complex and arcane sometimes. And then she was minding her own business, walking around the Johns Hopkins campus, I heard, and she was called and asked to be the acting Assistant Secretary for Health at HHS, which is a really important job that oversees a lot of the HHS programs related to public health. Beyond her, the job she's held, Karen has really had a tremendous influence on our field because she's thought not just about what's going on today, but what needs to go on, what the future of public health holds. And I think because of that, she continues to have a lot of influence through the various types of work that she's doing now, including at Dell Medical School in Austin. So it's my great pleasure to introduce Dr. DeSalvo, who will be talking about Public Health 3.0.
Thank you so much, Josh. It's really wonderful to be here and always to see my friend Josh, and wonderful to have a chance to share with you all this vision and work that's going on around Public Health 3.0, which is really just a way of kind of articulating how we can move to modern public health for the modern challenges that we face. And so I look forward to sharing a bit about that strategic framework and some work that's happening to advance it in the field, and then to have some dialogue, not only with the Dean, but also with you guys. The headlines in America about health often point to graphics like this of the problem that we're trying to solve, which is that healthcare is far too expensive and people aren't as healthy as we would want them to be. And in fact, relative to our peers globally, as I hope you all are keenly aware, we are pretty well lagging behind and spending, in general, about twice as much, and having declines in life expectancy now. Pulling out this graph for 2 years in a row, people are starting to die prematurely in the United States. And though it's particular to some populations, on average, it's creating a lot of concern. And I think a lot of the attention to this kind of trying to solve the problem of high cost, poor health has been focused on what the health care system can do. Can we make clinical care safer? Can we make it of better quality? Can we find a way to reduce cost by putting more pressure on the health care system? But often lost in this conversation is the underlying reasons that people are dying prematurely, and the opportunity to not just use the tool in the toolbox that has been health care and medicine for the last several decades, but to really broaden our appreciation of what are the other ways that we might really think about solving this really important challenge. And This kind of worry about problem solving is happening in a really dynamic national environment, particularly as it relates to all the actors who typically pay attention to health, including public health. And I want to start with this idea of why it is that people in the U.S. are beginning to die prematurely, why life expectancy is declining. It has historically been medical issues. It's been challenges around communicable disease. It's been challenges around chronic disease, malignancy. But increasingly, what we're seeing is that what's killing people in the U.S. are actually social causes. It's issues related to isolation, hopelessness, lack of economic opportunity, lack of educational opportunity, and it's manifesting in the death records as things like suicides, opioids, liver failure from alcohol abuse. And the epidemiology, therefore, is kind of outpaced our ability for any one sector to really address the challenges of mortality. It's not going to be quite as straightforward as developing a vaccine, as if that were straightforward in and of itself, but the complexities herein may turn out to be a lot greater. We're also seeing a lot of shifting demographics in the U.S., particularly the aging of the population, which, though I think often, we think, well, there's 10,000 aging seniors a day, and they're going to come with expected chronic disease like hypertension and heart disease. But what we're seeing is also in seniors an epidemic of things like loneliness and social isolation, which turns out to be a pretty significant contributor to not only their health outcomes, but also turns out to be a significant contributor to their health costs. We went through a period of financial distress in this country, the Great Recession, where resources, particularly in public health, were stretched. And I don't mean just on the front lines, but also at places like the CDC that typically is doing surveillance and trying to stay ahead of epidemiology and the challenges that our country faces. And I would submit to you that this stretching of public health resources from the federal level all the way to the local level and also into the academic environment has caused us to not have the kind of resources we need to stay ahead of the challenges that our country is facing, just at a time when I think we're needed more than ever. On the good, we have had a dynamic environment where there's been a digital revolution. Now, in some ways, this has brought to the fore challenges that maybe we might not have seen for a couple of years in more traditional approaches to public health surveillance. We know now, for example, that Twitter, that's appropriate for today, right, Josh? That the Twitter sphere is, the information there for local community is pretty well correlated with what's happening in particularly chronic disease or health behaviors on the front lines. We know that the digital revolution in big data is giving us better insights into social risk, not just into medical risk, and helping us not only to define the problem, but to predict which communities and which individuals are at risk. And particularly in the space of the digital revolution in the last few years has been the opportunity to map and visualize the health of the country in a way that was a little more clunky even a decade ago. And the opportunity here has been that because we can hotspot and because we can create these cool, sexy maps, people outside of public health and healthcare can very easily look at a challenge and get a feeling for, oh, rural America is having a particular problem with mortality. White middle-class Americans who live in these communities are having a problem with mortality, and it makes it more accessible to the average person, including the media, which is, I think, creates a tremendous opportunity for us to message and communicate across sectors and not just talk to ourselves about the health challenges that we face. The Affordable Care Act, love it or not, changed the landscape of not just healthcare and how people get access to affordable health insurance, but created a lot of ripple effects, including into the field of public health. It created an environment where the public health practice on the front lines was no longer as necessary to provide care, to be the provider of last resort, because people had insurance coverage. And so it sort of shifted the attention of public health away from needing to provide care in the clinical setting and to step back and reflect upon how it could make a difference in health more broadly. And finally, the Affordable Care Act, amongst other things, has really been pushing the health care system but also health plans, and in some cases purchasers or businesses, to really start thinking about population health. They can see it in the data now. They have a better sense that cost is typically concentrated in a few. They begin to understand that the people who are high cost are not just medically complex, but also socially complex. And these are challenges like going to bed hungry that typically are beyond the scope of what a medical environment does, and is really causing all those systems to reach out and look for better partners and public health often is the sector that comes up, the field that seems to be a logical support. In essence, what I'm describing to you all is that the country is awakening to the fact that our new health challenge and some of the important drivers of cost, that problem that we're trying to solve, is about the social determinants of health, which I might just tell you, sometimes I just call life and where we live it, which is maybe a little overly simplistic, but it really is, I think from an academic standpoint, as defined by Healthy People 2020, it's the conditions in which we live, learn, grow, age. It's also the context. It has to do with the built environment, it has to do with air quality, but also these very proximal challenges like economic opportunity, housing, the environment, educational opportunity and quality, access to healthy, affordable food, and the ability to live in a safe neighborhood and have the kind of transportation supports you need to get not just to your medical appointments, but frankly to your job and to school and to have social interactions that you might need. These are big, thorny areas that often cause some hand-waving, particularly by the medical system, like, oh, it's the social determinants of health and we don't know what to do with it. But this is squarely in the historical domain of the kind of work that public health has done. Defining public health as what we do together as a society to create the conditions in which everyone can be healthy. This is the way that we think in public health as being the neutral convener, to bring people to the table from different sectors who have different skill sets, who have different experiences, who have different assets to be able to create healthy conditions. It started for us years ago in what I would call the era of public health 1.0, which focused domestically in the U.S., was a time when there was a lot of uneven availability of quote, public health, but it was a time when we really began to apply the tools and knowledge of things like epidemiology or infectious disease to mitigate against the leading causes of death, the big problems of our time, which were communicable disease. So it was a time when we thought about things like clean water, clean food, flush toilets, vaccinations. It was a real opportunity for us to think about saving lives on a grand scale, facing the epidemiology of the time. We also in that time were involved in things like housing policy. So in the scourge of tuberculosis in the inner city in the U.S., the things that made the bigger difference in morbidity and mortality was not so much the drugs that we gave people for tuberculosis, but housing policy. Creating spacing in housing to deal with tenements where there was poor air quality and tight conditions, which led to increased transmission of disease. So even way back then, we were leveraging multi-sectoral approaches to addressing the public's health. In the phase of Public Health 2.0, I would say Washington got more involved and started to professionalize the practice, and schools of public health increasingly were thinking about how to make more standardization of not only the frontline practitioners, but of the field itself, including its methodology, and really began to understand what would it take to see that we had public health protection for everybody in this country. It was also a time when public health was called upon to address not just communicable disease, but chronic disease, diabetes, hypertension, obesity, to turn its attention to big challenges like HIV/AIDS and preparedness, adding additional burden on top of the work it was doing in 1.0, but doing this additional work to pay attention to the evolving epidemiology, what was causing morbidity and mortality in our country. And that sort of brings us to the world today, which is Public Health 3.0, this transformation that's happening in the field of public health practice, where public health is learning to engage, again, with multiple sectors and community partners to see that it can find a way to create this collective impact to address the big epidemiologic challenges of our day, which is really largely around the social determinants of health. When I was at HHS, as many people do in government, you get a chance to do something that's not the work of every day, but think about something strategic that you'd like to do while you're, quote, in the seat. And I wanted to take a chance. I guess I should back up. I wanted to take the chance while I was there to understand how public health was evolving into this world of public health 3.0, because you could see it and feel it, but I really wanted to get a better handle on the framework for what was happening on the front lines, and most importantly, what could be done to help local public health, state public health, and the feds really address these big challenges, particularly around the social determinants of health. How are people building healthy communities on the front lines? And so we set out an initiative that we called Public Health 3.0. We wanted to learn from the field about what was happening and what were the ways that not just government but the private sector could be more supportive to create a policy environment that would allow their work to not just evolve but to be sustained. We chose these 5 communities not because they're the only ones in the country that are doing Public Health 3.0, but because for a variety of reasons they represented sort of the best of the best, but also some interesting challenges, and they were in every time zone and every temperate zone in the U.S. We invited regional folks to come participate in the conversations, and we had about 100 people at each of these listening sessions. We also did some deeper dives in things like data and also into the history of public health that we hosted mostly here in Washington, but it was the field work that I think was most, frankly, inspiring for me. We had in the morning some bright spot conversations, and then in the afternoon we did workshopping to hear directly from people who participated what were the actions not only happening, but what would be the policy changes that would make a difference for them. And when I say policy, I mean both public and private sector. The 5 areas of the framework for Public Health 3.0 that quickly emerged and that we focused on that seemed to be the necessary components or ingredients were leadership and workforce, essential infrastructure, including of the health department, but how the community came together to work together. Strategic partnerships, what kind of relationships were these health departments developing that were outside of what might have been traditional? Who were they working with on the front lines to create the conditions in which people could be healthy? The 4th area was data, analytics, and metrics, and the 5th was probably the most important, maybe the 2nd most important. I argue with myself about this, but flexible and sustainable funding. It's all a nice project until you actually have a way to fund it longitudinally. But of course, you can't just give money to something that doesn't have really strong leadership and workforce. So I toggle back and forth between those areas of importance. After all was said and done, we published a report which is available still in the archived online, but also I give you the place where you could find it at Preventing Chronic Disease, where we were able to publish also all the recommendations. We had 5 overarching recommendations and 51 sub-recommendations. I couldn't quite get it to 50 because there was still the odd number that we were trying to keep in there. This is a report I just want to share with you all that went through clearance at HHS, and anyone who's been involved in government process will know that that means that everyone across Health and Human Services federally touched this. The NIH weighed in, the Agency for Healthcare Research and Quality weighed in, CDC was heavily involved, HRSA, so the Center for Medicare and Medicaid Services, everybody weighed in, and I would share with you that I thought people would sort of let it go along because it was this public health thing and nobody would pay attention, but perhaps most interesting to me was the NIH, who wanted to meet with us because they felt like there wasn't enough attention to the research opportunities to advance public health, and they wanted to add some more things that we had not included. At the end of the day, we had 5 overarching recommendations that correlated with our 5 areas of work, and they were about adopting a chief health strategist model, which is a way that leaders work in a multi-sectoral fashion outside of the walls of their health department. Remember, this is focused on public health practice on the front lines, but that they also understand their role and responsibility around not necessarily having to always be the leader, but sometimes lead from the side or behind. In that space, we also saw a lot of good models of it being not local public health leaders as the chief health strategist on the front line. Take, for example, a guy like former Senator Bill Frist in Nashville, who was a chief health strategist in that community and really helping to bring people to the table around public health. The second area was around structured cross-sector partnerships. The most successful models we saw were those that were not just, we're going to have coffee once a month, but we actually are going to form a 501c3 where we can share governance and and data and money and have a shared, that sort of take collective action and put it on steroids so they could move forward together. And it was little places, I say little, I'm sorry, Erie, Pennsylvania, but I consider you like littler, to Allegheny County, which is, has 110 municipalities, where they worked on ways, again, that it wasn't just them doing it by handshake, but they had formal arrangements that caused them all to keep coming to the table, and were bringing the best of the best resources to build more. We would call that in Louisiana like making gumbo. You put a little bit of everything in, and then you come out with something delicious at the end. To a site accreditation, so accountability to the external funders that we are accredited, we're a strong health department, we're spending money wisely. There's a lot of nuts and bolts about accreditation, which I'm happy to take answers to questions about and answers, but that essentially it's a structured way of public health becoming more uniform and having a set of skills around quality improvement and strategic planning and relationships. And we, for the first time at HHS, recommended that everybody in America is supported by an accredited health department. The fourth area was about having actionable data and clear metrics, particularly metrics that are not about individual, like infant mortality, but also thinking about community-wide metrics like smoking policy, complete streets policies in communities. And then the fifth area was about really understanding how to deal with funding for this work. We use the word enhance in the report. Now that I'm out of government, I'm a little more fuerte about that. I think it's, when in fact we know a number, we're underfunded by about 40%, and that's pretty consistent with prior work. But perhaps more significantly isn't just about putting more money into the system, it's about creating more flexibility. And for those of you in healthcare, I think you would recognize that we've been doing something very similar in healthcare. We have been, as opposed to do this for this patient and you will get paid, we've been trying to create more flexibility in the way people are paid, to focus on outcomes. And that's exactly the kind of shift that we need to do for public health so they can get the important work done that they want to do. So that report came out in October of 2016, and then we were asked to leave government. And I was really there until like the last minute on Thursday night, until the cleaning people politely asked me to leave so they could shampoo the carpets. I was sharing earlier with the dean that I didn't think that anyone would talk about Public Health 3.0 again, but I was wrong, and I've been delighted about that for the last 18 months, because what that report was a reflection. It was a mirror of what's happening in the field. It wasn't meant to be a top-down, here's the future of public health, although the APHA and others did think so. But it really has been an ongoing grassroots movement across the country, and I've visited so many local communities and states that are heavily engaged in evolving their model into being this Public Health 3.0 kind of model, and in some structured ways and in some organic ways. But I couldn't have been more thrilled when Dean MacKenzie published this, and it came to my attention, so I'm delighted to get to be here today to hear how you all are thinking about it. I won't go into all of these, but just wanted to share that there's a lot of ongoing national activity, some of which I'm involved in and some of which I find out from my Google alerts. And it's always fun to see that Illinois has developed a training academy, or Virginia's hiring people to focus on their Public Health 3.0 work. I think what I would say importantly is maybe, in the first place, the strategic partnerships work is getting a lot of excitement because of all the value-based care work that's happening in the community. That's a beginning, but not the full journey that we all need to go on. And there are some not only good tools out there, like the CDC High Five tool, but also CMS has in the field now, the Center for Medicare and Medicaid Services has in the field now a demonstration project called the Accountable Health Communities that was developed in the Obama administration and put out in the Trump administration, that really looks to see how partnerships work to address the social determinants. It's through a healthcare lens, but it's really creating a lot of excitement on the front lines about how public health works together. For example, in Tulsa, the health department is the partner convener along with the Health Information Exchange, so two of my favorite things, public health and IT, coming together to really create healthy conditions in the community. I want to just say a word about funding, because it's been something we've been spending the last few months thinking about to get to a number of what it would look like to have more flexible and sustainable funding. And there's been a really nice bipartisan effort around this to think about what is the legislative and policy change that would need to happen. For the first time, as best I can tell, we've come up with a gap number for the practice of public health, which is $4.5 billion per year, and that would include some money for a transformation center. Now, I talk about it like it's already passed in legislation and we're executing on it, but we're really doing a lot of thinking about what that might look like to get as concrete as possible. Last few minutes, I just want to talk about the final area, leadership and workforce, since I'm talking to current and future leaders in public health. And I don't want you to think this is just about public health practice, because if you are in the academy, you will be developing the science and you will be developing the future leaders in public health. And so I just want to make a few comments about what this means to really understand the development of chief health strategists and what are some of the finest examples that we're seeing in the field. The qualities of these kind of individuals, let me just first read sort of the general definition, which is that it's that they embrace this, you embrace the role, and embrace is a very important verb, really taking on a mantle that maybe doesn't allow you to take a quiet back seat, and work with relevant partners to drive initiatives, including those that address the social determinants of health. And these are people who are either skilled at or learn to work very strategically, to take appropriate risk, to work outside of their comfort zone and be humble and acknowledge when they don't know something in a field like the criminal justice system, but be willing to learn. And it requires a very entrepreneurial spirit to not only evolve your health department and your work, but also even things like your approach to data. This is, to me, such an imperative for public health, because public health leaders are the only ones that are truly accountable to everyone in their community by statute. This is one of the things that I learned overnight when I became health commissioner in New Orleans, is that when I woke up that morning, everyone who lived, learned, worked, and played, and that was tag, you're it. It wasn't just my attributable population in my healthcare system. And so it's not a fad. It's something that public health in particular needs to do every day. And public health is also good, and these leaders in particular, at knowing when they're supposed to lead, when they should follow, but knowing that they have to be at the table, even if their fingernail marks are on it as people are trying to scrape them away. And I think the last kind of quality about this is what I would call servant leadership. That this is really very mission-driven work, and it's not about who they are, but really about what they can get done with and on behalf of the community that they serve. In the interest of time, I'm not going to go into a lot of detail about our story of New Orleans. I think the dean and I are going to talk about it, but I get asked a lot about examples. One, and by the way, I know that y'all just had Lena Wen here, and Lena is a chief health strategist. If you're trying to get your head around what that looks like, and there's another person, Josh Sharfstein, who was a chief health strategist, and particularly when he was a public health leader at the local and state and even federal level, and now in academics. But so there are role models like that, and they're increasingly, I think, and I'm glad for, becoming the role models for public health leaders in the country. But there are a lot of very quiet leaders that you never hear the names of. We were talking about Rex Archer this morning, who's in Kansas City, who's been doing this for 3 decades, and really has just, these are extraordinary servants on the front lines. I had personal experience doing this in New Orleans, and at the risk of sounding egomaniacal, I think I was a sparkly health commissioner. The mayor asked me to come do the job because I brought a little bit of panache or whatever. And I walked down the street 2 blocks from Tulane School of Medicine and Public Health and thought I knew everything in the whole world that there was to know about public health and about health and healthcare and community New Orleans. And boy, was I wrong. I walked into City Hall, literally 2 blocks. I walked into City Hall, and within the first couple of hours, I thought, I know nothing. I don't know how the criminal justice system works, and public safety is our #1 public health issue. I don't understand enough about the transportation system or the housing system. And I just went on this wonderful journey of trying to understand how to improve health, but do it with 2 nickels and some friends. And our challenge, I showed you earlier about high costs and life expectancy. In New Orleans, the challenge was that the life expectancy differential was 25 years, just about 3 miles apart, depending on whether you live right behind the French Quarter and worked maybe in a bar or restaurant or hotel down there, or if you lived up by the lakefront and owned one of the hotels downtown. We were told by the consultant that we had the most dysfunctional health department and city government that he'd seen in 25 years. And I knew that actually before I took the job, which tells you a lot about my insanity. And this was the background of this picture was actually just one of the many doors that we opened when we started trying to do inventory to understand what was going on with the health department. My deputy director and I, and we'd open the door and be like, oh, geez, when we close the door. It was just so much literal cleanup, but it's, I think, a representation. It wasn't just that we cleaned up rooms. We cleaned up policies and our relationships and developed a strategic plan with the community about their health needs and a way forward to make improvement. We cleaned up our books, our finances, trained our workforce in quality improvement from A to Z, and we used accreditation as our blueprint for that pathway forward because there wasn't really any other way to move forward, and that was all new at the time. And this was from a staff meeting that we had about being a model for the nation. We had just won a prize and we're on our way to doing accreditation to be one of the first accredited health departments in the country. And this team of people, and then some, are the extraordinary human beings who toil every day on the front lines to see that the people of New Orleans' health is protected, not only for the today, but for the generations to come. And they went through a really difficult journey because they moved from a time where they were really focused on communicable disease and chronic disease and siloed programmatic work. I do WIC, I do Ryan White, this is my program, to really beginning to understand that they'd have to not only work together, but work with the community and be willing to go into places, spaces, partnerships where we might not have traditionally had conversations and really be thinking about the future of our city and not just the work that they had to get done for the grant program that they had today. We did a lot of great work, but one of the things that I wanted just two things here I wanted to highlight. One was the focus of our work was around something called FitNOLA, which was our version of Let's Move. And FitNOLA had a very positive frame. It was so named by the children who helped us develop it. It was about nutritional and physical fitness. No scientists to get all crazy on me there, but that's what we called it. And in reality, a lot of our work was attending to mental health issues and public safety because those were big barriers to nutritional and physical fitness, as well as poverty and housing. But we really put a very positive frame on it and tried to do a lot of really events with kids, and it's ongoing into today. So I get off at the airport and there's like signs for FitNOLA, and it just feels really good because the community has really taken this as a way that they want to change the culture in their community. And in fact, we're recognized by the Robert Wood Johnson Foundation as a Culture of Health Prize winner, and we got the headline in U.S. News and World Report, and it said like, can you believe that New Orleans is being recognized for being healthy? Who would have thunk, And I loved that because who would? But we chose that as a community, we wanted to be healthier. And in fact, carried forward into things like a smoke-free ordinance for our city. And now, actually, the councilwoman who carried that legislation is our mayor. So much more to come. All right. I just want to end by saying that you all are, in my estimation, studying exactly the right thing. And if you're not studying it and you just happen to be here, then you should be studying public health. Because the big problem we're trying to solve about cost and suffering and death is not going to be solved with medical care. I'm sorry. We're going to have to think a lot bigger. And we're going to have to find a way to bring everyone to the table, and public health is just exactly the right kind of field that is accustomed to doing it, that can think systematically and strategically to really address all of those determinants of health. It will require a lot of transformation of public health. I articulated for you the way some communities are doing it, the Public Health 3.0 framework, and the ways that they're evolving themselves to think differently about data and relationships and their own structure, as well as leadership. And so I would submit to you it's a blueprint for the future. The name less important to me than just the fact that we recognize that we cannot keep doing business as we always have, because there are a lot of people counting on us. And I think that my final couple of thoughts here are that the kind of leadership that we need in public health is very diverse and collaborative. I described to you this kind of chief health strategist role. I also want to emphasize again to you that in communities at the local, state, and federal level, it doesn't have to be the appointed public health governmental agency leader. We are seeing fine examples where the business community, the digital sector, the medical sector step up and bring people to the table. And I think that sheriffs in San Antonio, I know that that's okay. What matters is that we all begin to work together in a way that is much more collaborative to solve these big challenges. Victor Zhao, who's the head of the National Academy of Medicine, has started talking about convergent science, which is really bringing all of the best fields together. And I think he's exactly right. We can't keep the science of our field separate. I would submit to you also that we must begin to think about convergent practice and policy work, because this new era of the 21st century with our big challenges is going to require us to not just understand it differently, but to absolutely act differently, because we have to work together to create the conditions in which everyone can be healthy. Thank you all so much. I look forward to your questions.
Well, good morning, everybody. Let me begin by thanking Dr. DeSalvo for being with us here today. She's a very busy person doing lots of great work out in the front lines, and we do appreciate her taking the time to talk to the future leaders of public health. Also, welcome. I think the last time we got together collectively was maybe at orientation, so I hope everything's going well. You're surviving Dr. Sharfstein, which, you know, is a major feat in and of itself. But it's great to be with you here this morning and look forward to the conversation. Now, when we invited Karen to come and, you know, we talked about some of the questions we'd like to ask, she made a big point of making sure that we save enough time to get the questions from the students, and I think we also have some faculty here in the room, so we do want to make sure we have plenty of time left over to get your questions asked and hopefully answered.
I was in government, so I know how to not answer questions. I'm really good at that.
I need to learn.
There's like a whole training on it. Yeah.
Well, let me begin by saying I am a big fan of you and the vision that you and your colleagues had in thinking about Public Health 3.0. I just want to say one thing. You flashed up the very beginning sentence of the column I wrote in the magazine. And for those of you who have not read the whole article, you should, because the front line says Al Sommer, you know, who is our 2 deans ago. You know, I say that I had this conversation. He's saying, you know, the problem with public health is that, you know, we consider everything part of what we do. But I go on later to say that things have changed, and Al Sommer is one, you know, I would say that he is one of the strongest supporters of the principles of a Public Health 3.0. So his thoughts on this have changed dramatically. So I just wanted to underscore that.
I didn't even notice that. I'm sorry.
Yeah.
Sorry, Dr. Summers.
So you mentioned, as you know, as assistant secretary, you have an opportunity to think big and think strategically, and I feel the same way as dean. It's one of the fun parts of the job is the opportunity and indeed the mandate to think about the future of public health and public health education, and to think strategically. And I shared with Karen this morning that we are in the throes of developing a strategic plan, and the principles of Public Health 3.0 are figuring into that plan. So we might talk a little bit about that later. But let me begin by asking you, so I think we can all buy into the vision of Public Health 3.0, and I'd be curious to get from your sense as to what the reaction has been, both in the field and the more traditional public health field, as well as outside the field of public health.
So change is hard, and especially change when you don't have a lot of resources. So I have found in some cases that the status quo there's a group of folks in the status quo who believe that the domain of public health is the programmatic services work that we do, and that we should not be in the business of being a convener of stature or of rocking the boat, basically, in how we do work. So there is some establishment who I think are concerned about the evolution, and there are some. There are some very small health departments that are worried, and then some large. I think what's interesting to me about this work is just that point, because there's this other whole group of folks who are like, well, I'm glad y'all don't think that this is the sort of practice we should have, because we've been doing it for a few years, and here's all the things that we have accomplished and what we have learned. And when I say the we, I'm talking even about sort of very small Kentucky local health departments all the way to big cities. So it's not just the domain of an urban area or a rural area. I think they've found a way to embrace this idea that they're a strategic leader in their community, that their job is not just to run programs or to regulate, and to use this as an entree into broader conversations. So it's mixed, Ellen, and here's the thing that I'm going to say bluntly, which is that the practice of public health is going to die unless we evolve. And this recession that we had was a near fatal blow to the practice of public health, particularly on the front lines at the layer below state government, because the budgets were so severely cut and there were such severe layoffs that it was very difficult for them to continue to do their work, and funding from philanthropic sources dried up, and their relevance in their work is also evolved. Now, sometimes this manifests in a very dramatic way. So think of what happened in Flint, Michigan, and that Genesee County Health Department, Flint is a part of the broader local health department, for years had a pretty good sizable budget, was doing a lot of work that was multi-sectoral, really engaging outside of their programs, but working on things like health and all policies, but even more broadly, housing work, et cetera. Well, when that funding shrunk, by the time the Flint situation was happening, they were working at 25% of the budget they'd had just a decade prior. 25%, right? And they still have the same statutory expectations, plus they weren't able to do some of that additional work that's not what we would call public health 3.0. So working with the Water and Sewerage Board to understand what was happening with water quality and safety, even though they didn't run the water system, this would be a natural place that public health would begin to try to think broadly about health and safety. And so this is not a knock on Genesee County Health Department, but an acknowledgement that that's an extreme example of what happens when your funding shrinks and it's difficult for you to practice in a way that's more strategic and broad what the health impacts can be. And so I don't want to be, so on the flip side though, I think what communities not only like New Orleans, but many others have figured out is that it is possible sometimes to do more with less if you think about this as not just what assets do I have as a health department, but what are the relationships that I have, and how can we bring more data and resources to bear. And that's why these communities that particularly are creating these structural partnerships, like in Allegheny County, for example, where they've got this umbrella organization that allows them to share housing and transportation and parks and rec money, all to the effort of what the strategic vision is they have for a healthier community. But they're also sharing data, including social determinants data, so they can make better decisions, they being all these different sectors that have come together. And so even in the face of this challenge, the front line is innovating. And I hope that the establishment doesn't hold it back. And I really, that's why when I talk about the clearance process, I was so excited when some of the establishment career folks who think a lot about public health thought, oh, this is great, and here's how we can help to make sure that the work gets done better on the front lines. Sure.
You talk a lot about the importance of partnering across the board, but in particular partnering with the healthcare system. And getting back to the funding issue, you talked about the potential of it sounded like to me were some new sources of funding to support this new vision. But what about the potential for taking the savings that are coming, if we can deliver on impacting social determinants that we know are a big factor in health outcomes. If we can make inroads in that and we save money in the healthcare system, what are your thoughts about using some of that savings to pour back into the programs that we need to continue those successes? Is it possible?
Sure, and there's so it's really complex, and let me just start by saying I think part of our challenge in 2018 and beyond is something that we did 100 years ago, which was to begin to really separate the fields of public health and medicine. And we did that because medicine was developing its own set of tools and skills and was the favored siren sister. And public health had a longer trajectory of impact. And, Hygeia health is harder to measure. And we don't actually have an actuarial basis for our work. We don't have a way to tell the people who score legislation or for them to tell us, or for the actuaries who work in Medicare program or at health plans to really understand the value of what prevention in public health is. And so here we are in this little bit of a pickle where it's difficult to articulate what is the value add that is brought to the table. And so medicine has gotten the money, 97% of it, and the attention, and it impacts about 10% of the health outcomes. So the question would be, do you transfer money from medicine to public health, and do you do that after the fact? So do you create models in the field that are maybe a next generation of accountable health communities where public health and medicine create a collaboration and they share in the gains? So whether it's at the state level in Medicaid and public health programs or further afield in the private sector, is there a way that if you spend less money because you feed grandma and she doesn't go to bed hungry and so she doesn't end up in the hospital because she chose food over her medications for her heart failure, then does everybody accrue those savings? We won't even talk about the community and the patient, but let's just take public health and medicine. Do you accrue those savings to both places? There is not a model like that yet in the country. There's a couple of places that have started to think about that at the state level. One state in particular, would it be possible to merge those two budgets so that there could be some shared savings? So that is something we should try. I think the power structure there worries me because all this, they have the money, they have the attention, I say that like I'm not, but whatever. Medicine has, but the how quickly she forgets it, and so I worry about public health being eclipsed. And the only reason I worry about it so much is because medicine, for all the good that we are doing to move to value, is still mostly a sickness model. And so we do well in medicine if we do things to sick people. And so that kind of has this, an incentive structure that you don't want people to be healthy and to prevent. And so there's also I think a malalignment. There's also a problem where medicine does tend to still think, even though we talk about population health, it's very individual focused. And so we're still thinking about, so the medicine's approach to this is to medicalize the social needs and not really as much yet think about structural change. Now there's great examples like Kaiser who are well beyond that. So Kaiser doesn't just try to do ride share for people who can't get to their appointment. They're changing the transportation infrastructure in the communities where they operate to see that there are better bus lines and better train lines. So they're a great example of how this, if that went well, you're kind of how that could really play out. But I think that the last point I would just say is I'd like to give a run also at just strengthening public health. And in all the ways that we've described, and seeing if there's a way that public health and social services, by being strengthened, can create a policy and personal environment that makes them a better partner to medicine. So medicine can focus on medicine, which is also really important.
I should add that Karen is the president-elect of
Society of General Internal Medicine.
The Society of General Internal Medicine. So she's either going to alienate all her know she's going to just revolutionize.
Oh man, I know.
The medical
it's
field.
It's the both parts of my brain, and I bet you there's some physicians in the room or physicians in training, and it's since as I have gotten smarter about this, it certainly happened when I was practicing at Charity Hospital for years and years and years, and my patients, the medical part, complicated but relatively easy compared to how do I get to Angola to see my kid who's incarcerated, or my kid needs a substance abuse or substance use training, a treatment program, or I need a literacy class because I can't fill out job applications. I just didn't know how to help them, and I was sort of self-teaching to do social support, and so I knew that there was a challenge. But the more I began to understand the data that most of their health outcome was related to stuff that was out of my direct control, it has been an internal tension about where to apply myself. And I think both are possible, but it's important that doctors understand, and medicine understands, that there's a 99% of the time people are not with us, and we need to be leaders in helping make that a healthy environment.
Yep. Well, we look forward to your having an impact on that in moving forward. Since we're a school of public health, and given that we're in the throes of writing our strategic plan, I'd love to get your thoughts about what we should be doing in training the future leaders. You talked about several characteristics of a chief health strategist, but what do you think we should be doing that we're not currently doing as good a job of in training?
Let me start with just the workforce component, and then I want to talk about the science a little bit. The workforce piece is that most people in U.S. Schools of public health programs and schools of public health don't go into the practice of public health, which is fine. So I think there needs to be a recognition that what you're training folks for isn't just frontline work, though people toggle in and out of it. And I would encourage that for folks, if you have an opportunity to have an experience, especially at the municipal or county level, to work in public health. It's a very granular, quick, real experience, and I think you'll understand. It'll help inform your science or your teaching further down the road, because just like in the practice of medicine, if you're going to study cardiology, you should have practiced it a little bit, or at least had some exposure to it, so that you can have a sense about what happens really on the front line. Same thing with policy. So I think just acknowledging that that's not all that you do, but on the other hand, I think there's some ways that you could enhance the universal exposure to public health practice. And there's a couple of I know that you all do work with the local health department here, but just to give even further examples, like in Lawrence Douglas County, Kansas. I've been spending a lot of time in the Midwest. They're very excited about Public Health 3.0. In Lawrence Douglas County, Kansas, they have a formal MOU relationship with Kansas University. And they share employees, data, money, visioning, space. They have what they call an academic health department there, and it's been a way that, again, they've been able to augment the experience of their students, but also the opportunities to improve community health. There's models like that in North Carolina, and that again are at the local level. I think we see these more commonly at the state level, and this is an opportunity for students to have a real world experience about the challenges that communities are facing. But I think it's also a real boon for the health departments. It's an infusion of ideas. When I was in New Orleans, we structured that in a way that led to recruitment of some really fine employees out of the School of Public Health, but also perhaps more significantly led to us developing a defined behavioral health program, to developing programs around intimate partner violence and child protection in our WIC program. So we were able to pull from the assets of the School of Public Health because of the formal relationship that we had to do things for the community that we couldn't have been able to do alone. And I think on the other side, in terms of research, I just want to say two things. One is that the practice of public health doesn't do a very good job of describing or evaluating its work. And so it's very difficult to get outcome measures for things like 3.0. I've been reviewing papers that are coming into the literature, and so people are starting to, but, and I don't mean just for 3.0, but just in general, what are the leadership models that work, et cetera. And so the practice of public health really needs your talent to put some formal structure on understanding what works on the front lines to improve the community's health. I think the other area where I'd love to see a lot more scientific advancement is in the data space. And this is a source of great frustration to the practice of public health on the front lines. And to me personally, it's one of the things that caused me to go from being health commissioner to being the national coordinator for health IT, was because I didn't have data to make real-time decisions when I was health commissioner in New Orleans, but I knew it was all there because I'd been running health systems and I knew asthma rates and I could map them, but the hospitals wouldn't give it to us because of their own proprietary and HIPAA and you name the excuse. So all the work that I subsequently did in data blocking and in requiring APIs or doorways to the data in the electronic health records and money we seeded in communities to get social services interoperability going was driven by that sort of public health experience I had, but that's just the beginning. I think what we're learning from projects like the New York City Macroscope is that data from electronic health records that even as a non-random sample of the population is pretty well correlated for some conditions with a random sample of the population. So it's a pretty good way to get enough data to do quality improvement, which is sort of where I'm going with this. Is that public health takes too long to evolve. So most of the data I had in practice was 2 or 3 or 4 years old. It was so perfectly curated and beautiful, and that's great, but it means nothing to me. I need to know if what I did last month or last year made a difference in risk factors for this community, or I need to look for emerging issues, which is the place I mentioned Twitter earlier. And this stuff with the opioids, for example. I mean, well, we should have known that in a more we're learning that Twitter, as one example, it's not just Josh and a couple other people that are on Twitter all the time. It's maybe I should point to myself too. It's
and she'll retweet
it. Is that again is correlated. It's not a random sampling, but it's pretty well correlated with what's happening in a community. And as a health practitioner, I need to know what are emerging issues and where are those emerging issues happening. And so the better. And we think about that sometimes of like surveillance data from ER about about signs and symptoms of communicable disease or about new emerging pathogens. But there are other things like opioids that we should be paying attention to. And so this is where it's not just about I think the science needs to think also about available public data sources that are anonymized, whatever, that can be used, and turn that into a more acceptable scientific method. Things like that, small area estimation. There's a lot of ways that you could advance the field that would make the work on the front lines less stale and much more relevant, and I think we could do more to get ahead of challenges.
Yep, huge challenge, yep. In your talk, I think you referred to understand and moving the needle on social determinants a big thorny issue, and I think we'd all agree with that. And I guess the question I have for you is, it can be very frustrating. What message would you want to send to our future leaders of public health about not getting discouraged and continuing to work on addressing those deep-rooted social determinants?
I would say 2 things. One is it looks like, there's another scientific opportunity for you, it looks like just having an awareness matters. And the second is that you have to eat the elephant one bite at a time. And so in the first case, going back to a clinical example, is, and this is the doctor public health hat, I, for example, don't think that in the clinical environment, doctors should be asking people if they're going to bed hungry. I don't think that we should, in the primary care or ER environment, ask structured questionnaires. I think that's anyway, we could talk about why, but there are privacy issues and time issues and burden issues, and doctors don't know what to do with it, and it's just but that's kind of a way some of the field of medicine is encouraging, like the pediatricians. On the other hand, this question should be asked, and there's lots of ways that is happening in the field, and that we're experimenting with the most private and ethical and humane way of asking people if they're going to bed hungry, and addressing those needs and using data to estimate risk before you even go in and ask someone an embarrassing question like that, right? But on the other hand, it turns out from some preliminary data done at NYU that if you, as a doctor, acknowledge that the person's got a social context outside of just the medicine you're prescribing, and ask gentle questions like, how's everything at home? Do you have a home? Like, what, when you'll sort of learn that patients are more adherent to their care plans. And so not even because you did anything to get them access to address a social need, but just back to context. There's a guy named Saul Wiener at University of Chicago, I think, or Rush, who's done a lot of work on contextualizing health, and that we can't just prescribe insulin. We have to know if somebody has a house and has electricity to keep the insulin cold. And so, but it doesn't mean you have to find them a house or get their electricity fixed. The system, though, should be able to make that work. And that's the sort of one bite at a time. I think where even in the last 18 months, where the opportunity is going from a data standpoint, an innovation standpoint, and the way systems and health plans are thinking about it is taking big data and risk stratifying populations to get a sense of who is most likely to have risk, and what accounts for most of that risk, and how do you prioritize all the social need they might have? Is it housing first? Is it transportation first? Some systems are deciding that it's not, even if it's transportation, but they don't have a solution set for it, they tackle what they can. So there's a FQHC in Austin called People's Clinic that decided they have great food system support. So they're choosing to target food insecurity in their population and not deal with all the other social determinants. So you can pick one SDOH, you can pick the highest priority. And the last thing I would just say is that some of the work has been to also think about from a very analytic standpoint and look at self-report of healthy days, and which is pretty related to cost and outcomes, and then understand in the population what's causing changes in healthy days, and in this case it was food insecurity and social isolation, and then address those things. So use a multivariate model to figure out what are the high impacts. So there's a very scientific approach we could take, but you don't have to do it all at once, because it also turns out, by the way, that and there's some good thinkers in this space who are thinking that maybe things like food insecurity are a marker of a lot of other social determinants needs. And once you kind of get in there, you realize, well, you're food insecure because you don't have enough money, or you don't have a house, or you don't have a car, or transportation. And so it begins to unfold a lot of other conversations. But again, just pick a place to begin. It doesn't all have to be solved at once.
Yeah. It's challenging, though, because you're targeting one particular piece of it, and at the same time we keep saying we've got to take a systems approach, and we've got to look at it, how they interplay and how they impact, and
there are whole companies forming to take a systems approach, and so there's an industry evolving around this, which has good and upside and downside. I think what I'm really concerned about right now, we mentioned earlier, and it's kind of two things. One is the medicalization of the social determinants, and the other is the excessive amount of activity in the space that isn't connected to itself, and so and as a result, a lack of an agenda around it. So from a research standpoint, as an example, we do not as a country have a research agenda to understand how the social determinants of health should be understood and tackled. There's a group called Siren out of UCSF that's trying to pull together scientists, but there's not a National Academy of Medicine research agenda around it, and I think some of us have been talking about that in a way that we tackled things like HIV or cardiovascular disease, like who's going to do what when, so that we can get the answers to these challenges. But right now it's kind of like a bunch of spaghetti on the wall, and I don't think that's going to serve people or communities as well as I would like something more systematic.
Sure. So I'm getting the signal that we should throw it back to, but can I ask one more question?
I'll be quick.
You started in academia at Tulane.
Yeah.
What went into your decision to move quite dramatically from academia into the throes of public health?
It was probably my patients. And over time, as I've reflected on this, it was a series of patient encounters that I described a bit earlier, where I medically knew what to do, but socially didn't. And it started for me to building medical homes. So after Katrina, when we were all on the street doing our work and we're rebuilding our healthcare system, we built one where clinical medicine, social services, and even public health could work more tightly together with community. But I kept, even in those environments, as great as it was to practice medicine or run those, or think about how we were advancing the community's health, it's like you come to the edge, and then I'd look across and I'd say, well, this is where medicine ends. And on the other side is the criminal justice system, or parks and recreation, or transportation. Concrete example about transportation, the new map for transportation came out for the city of New Orleans after Katrina, and it still had the buses all the bus changes, the crisscrossing, I can't think of the name of it, someone help me. Thank you, the transfers happening at Charity Hospital, which had been closed and was like a blighted building. But that's the way the transportation system thought that healthcare was received still in the community. But instead we had dozens of community health centers all in the community that were brand new, that there were not bus routes for it. It was those little moments like that, Ellen, where I thought, my patients are telling me they need more than I can give them medically. So I want to understand who makes the transportation system decisions, who's deciding about criminal justice, who's deciding about housing, how can I understand their frame, how can I influence them, how do we reshape the conversation? And that, I went against all advice from all my mentors to becoming health commissioner, and it was like the best decision I've ever made.
Great. Fantastic.
Next to being a doctor. Second best decision.
Great. All right, so this is your opportunity to ask some questions. So we have some mics, do we? I don't see them, but oh, there you go. So if you'd raise your hand, we'll get you a mic and introduce yourself and ask a question.
Right in the front.
Oh, there you go. Nick, we're all the way down here in the front.
Oh, and then there's one.
Sorry.
We enjoyed the discussion very much, and of course the lecture itself. I'm Halida Akhtar. I'm a new faculty addition to the International Health. I originally come from Bangladesh, but I'm also I did my MPH and DRPH long time ago. You've said certain things, and I look at the trajectory of public health. I see that science, and I see that how science is converted into data and information to do advocacy and to communicate with the community. And the third one, I see community as a beneficiary, but it's not only the beneficiary, they are also the actors. And I liked what you did say, that there's a community leadership, but at the same time I saw it's a servant leadership. Can you highlight a little bit what do you mean by that? And in my feeling and my understanding of running large programs, I see that community ownership is very important. And giving the responsibility to the community is very, very important. It's not that you and I, public health practitioners, are responsible, but they are also responsible. When we talk to the transportation, your last sentence, like transportation, they just don't only drive things, but they have to think how they save lives of people. So how they relate with the people, not that transporting them, But as we see that the public health is related to transportation or the environment, so that communication to them is equally important to make them responsible.
There's a lot in there, but I just want to get to talk about the community component to it, because as the and I'll start by saying that when I became health commissioner in New Orleans, looking at the data, knew that cardiovascular disease and cancer and infant mortality were leading causes of death in my community, and there may be some medical ways that I would have approached that. But as we did, went out into the community and did our community health assessment work, both qualitative and quantitative data collection, we heard over and over again, no matter what zip code or the color of people's skin or their income status, that personal and community violence were the biggest challenges that we faced, and mental health a close second, which wouldn't have been on the data radar for a bunch of reasons. It's not measured, but it was also, I think, it was a powerful lesson to me that you have got to listen to community to understand what's top of their mind. And that translated for us into, I think, a relationship of building with them and building with youth as an example that is difficult, but if done right, they have an ownership over it in the way that you're describing that lives well beyond your tenure as health commissioner. And that's the most important thing. Because for me, the fact that work that we started when I was there lives on because the community carries it forward and it matters to them, tells me that we touched the right spots for them. And at the end of the day, though, there's an element of what you're describing and what I see in Public Health 3.0 that has to do with civic engagement. This is not actually really about health, if I can be perfectly honest. It's about people caring about their community and their neighbors, and health is one way that manifests. So I would hope that we start to move back as a society to a place where we know our neighbors, where we think about all the tools at our disposal to improve not just health, but well-being.
Yeah, good point. I think there was a question. There we go, right in the middle there.
Yeah. Hi. So I'm wondering, you mentioned the social determinants of health, and these are very diffuse factors, diffuse risk factors. Can you please repeat the question? Sure. Hi. So I'm wondering about the social determinants of health, and you also mentioned the need to collect actionable data. So when you collect data and you look at all these risk factors, it probably moves up the needle by a little bit, but how do you really make a compelling argument to policymakers who want the biggest bang for their buck to change these systems? For example, if I build a new playground in a neighborhood, how do I measure the improvement in health due to that playground effectively and convincingly? These things aren't easy to measure. So how do you make that argument when you do want to change the health of a community for policymaking?
It's such an important question because in the first place, I'll tell you that the policymakers at HHS right now are asking that very question. Mm-hmm. They want to understand, if this matters so much, what is the current state of the evidence and where do we need to go next as we're trying to think about what in their world, particularly the medical system and payers can do, but also what they should be doing as a leader, partnering with housing and urban development or transportation. So let me tackle it a couple of ways. Let me first of all say that for the scientific community, we do have a lot of work to do to bridge town and gown between the purity of our science that we do in our academic walls and the messiness of what that happens in the field. This is not new to social determinants. The fidelity of any model that we develop in public health, when you roll that out in the field, is gone. There's a lot, right? There's a lot of confounding, and people don't behave the way that you think they would, and natural disasters happen, and on and on and on. So I think we just have to accept that that's something we have to get methodologically better at as a field. But I think secondly, we have to also accept that while we're sitting around worried about it, Silicon Valley is just trying to solve for it, and so are the health plans. And I'm loath to mention the names of any companies unless I'm permitted to do so. But I don't know. But what I would tell you is that while we sit around and try to decide, well, what's the best science for that? There are some big name Silicon Valley companies and then some smaller name companies based in places in the Midwest that are saying, oh, give me all that dirty data and I'll give you a pretty good estimate of who's at risk, who's a struggling single mom in your community, and what we might need to, that is literally the category one of the companies has, and we'll know based on the kind of car she drives whether or not she's likely to smoke and use the ER in the coming year, and we're going to be able to come in and do an intervention, and we're going to reduce costs. There's enough money on the table that the IT and data and Silicon Valley community sees that and is going after it really quickly. And the models they're building are probably overfit, and they probably are going to call people struggling single moms as opposed to something that's maybe a little more, whatever, a little less labeling. I'm serious about that. So there are a lot of reasons why I think we should stay involved, but I just want to let you know also that world is evolving even without us, which all to say is that tells me it's possible to take a big mass of data, and because so far what we're seeing is that they're fairly right. And again, we don't have a lot of long-term studies. I think the last piece I would say to you though is this I mentioned actuaries before, and maybe this is the third time I'll say the term actuary in a public health meeting. The Society of Actuaries actually has a public health section. Some of them are starting to think about social determinants. I would say if I had to put a bunch of money someplace, it would be to get them to advance their field, because to your point, the science is great, but the policymakers are going to care about the cost reduction, and there is interest at the federal level to make that happen. So. I don't have a specific answer except to tell you that, and I'm not telling you to go work in Silicon Valley, but I'm saying that which could, but that there's a bunch of folks working on it, and that we're starting to see that it is possible, and I wouldn't be daunted by the enormity of the challenge. Again, you just have to systematically begin to approach it, and I think what we need to do is to start to quantify it so that we can have some alignment of outcome measurement. Here, we did this, and these things happened, so we know that if people don't go to bed hungry, then there are lower healthcare costs. So everybody should at least be doing that. Now we'll work on the next thing.
Yeah. And that's why all the biostat and the methods courses that you take as students are so important. Let's see, right here.
They really are.
Yeah.
Yes.
Critical.
Yes.
How does climate change fit into Public Health 3.0?
Ooh, that's a big one.
A small question.
Yeah. I think I love that question, because climate change is an acceleration of the challenges that we're facing. It's an acceleration of the need to appreciate the context in which people live, and the lack of resiliency in communities that have a lot of inputs, not just isolation, but poverty and safety. We know that when people have a better social cohesion and other higher levels of social determinants, less need, I should say, like from the Chicago heat wave, that there's less mortality in some of those neighborhoods. We didn't quantify that in New Orleans really, but I can tell it to you anecdotally. So being a public health leader, addressing the housing and social isolation and poverty and electricity dependency needs of our population became increasingly important for power outage, et cetera, things that are starting to happen more commonly for climate change. I do think public health also potentially has a role to play in helping the healthcare system be a major leader in mitigating against climate change. There's some interesting work that not only big national systems have done, but that is being led by nonprofit groups to help health systems understand what their emissions are like, how they can build smarter, how build their institutions smarter, how they can be better partners with their clients in the community who maybe have pulmonary disease and might be impacted by fire, et cetera. So there's a body of work happening there, and in a good way, it's a lot of the medical community's leading it, but public health ought to be tapped into it to understand, because it's a fifth of the economy, and they can make a big difference in mitigating against climate change, but also supporting people when events happen.
That's way in the back. Good. And then we have one up here, and we have two up front.
Thank you so much for your talk. My question is about partnerships. So you've talked about what seem like internal public partnerships and then partnerships with the private sector. And it seems to me that there are some fundamental tensions when trying to partner with businesses. A classmate of mine actually recently told me about her work in food insecurity and how Walmart, for instance, is now kind of contributing to public health campaigns to reduce food insecurity for children, which strikes me as ironic, of course, because Walmart doesn't pay its workers a livable wage, which contributes to poverty, which is, of course, causing the food insecurity. So when we think about having a structural analysis of things like poverty, like you've mentioned, right? And how do we navigate like partnerships with businesses, which I think are like fundamentally not interested in addressing some of those core values?
I might take a slightly different, more optimistic tact. Y'all might be noticing that I'm relentlessly optimistic. So I do believe there's a lot of private sector policy opportunity. And particularly in the areas of them thinking about their civic leadership responsibility. They are a big voice in the political sphere and have a lot of opportunity, if they want to apply it in that way, to making positive change, whether it's about things like smoking policy or establishing a living wage for communities. So there are, and there are examples of small and large, of how corporate America and local businesses have been a force for positive change. Down to think, anyway, I could give you examples, but I won't do that in the interest of time. But think broadly about, particularly at the policy level, including at the local community level, how they have a shared interest in having healthy employees. So things like smoking bans, or complete streets, or parks and rec funding policy can be a really nice place of initial natural alignment. They do have internal opportunities, not only to think about how they manage and treat their own employees, but also about their opportunities as an anchor institution to buy locally, to hire locally, to work with local institutions of education to advance educational opportunity. There's, again, examples like that in many cities and rural communities around the country where there's beginning to be, I think, some positive change on the part of companies. And I'm going to end with this comment, which is to say, we're not all going to agree on everything. And if we spend more time thinking about places where we disagree, the numbers on graphics like rising cost and rising mortality are going to keep going up. And I would encourage all of us to recognize that, most importantly, we need to find some common ground. And so where we can find a place where we have a shared interest in things like smoking policy, as an example, let's run with that and do as much as we can to improve the public's health. And over time, when trust and understanding builds, I think we'll have more opportunity going forward, and we may agree more than we realize, and just try to not get too caught up in the rhetoric.
Mm-hmm. I think we have time for maybe one or two questions here in the front. Is that okay?
Hi, my name is Sarah. I'm a family practice physician. You spoke about mental health and how it's becoming a primary determiner of physical health. How do you see the bridging of the gap of lack of payment for mental health services? And as we move towards that, how can we prevent the loss of a critical mass of mental health professionals when there's already not enough to go around?
So a couple of things. One is that we're dramatically underfunding and under training and under resourcing the need to address health more broadly. So let me just start by saying I acknowledge and agree with that, from little bitty all the way to seniors. And we have some targeted efforts that we tend to do in response to crisis, but we're not doing a very good systematic approach. And you know, people talk about trauma-informed programs, which I think is great, but I think also we want to prevent trauma, and so I'm a big fan of trying to also think about making every zip code the kind of safe place where you could live in your home, et cetera. So we have a lot of deep work to do. I would say, though, that we've made some progress. And so I don't want you to feel like there's not been change, because there has been, and I'll point to President Obama and that administration, not only with the Affordable Care Act, and so far we haven't lost ground on the need to pay for behavioral health services, but also that there's a destigmatization that's increasingly happening, and that's really going to be important. I think the opioid epidemic and the behavioral health issues are complicating this, quite frankly, and they're getting that part of the behavioral health challenges, the substance use disorders, getting more attention. And the reason I raise that is just simply that I don't want us all to lose sight of the fact that opioids aren't just because some doctor prescribed it to you and you got addicted. There's a lot of other reasons why this country is dying of addiction, and it has a lot to do with the social determinants of health. And so not only to prevent that, but to keep people in recovery, we're going to have to really address the social determinants on the other side. So we've made some progress, and I think there's increased attention, though we definitely, I think, are going to have a significant amount of work to do. And one last point, which is kind of a little wonky, but as part of the Affordable Care Act and the expansion of Medicaid, some Medicaid programs in the country the trend for a while was to disarticulate mental health programs and behavioral health from Medicaid and public health programs. Well, at least in the Medicaid program, the physical and mental health have been getting merged again, and so the companies, the managed care companies that are responsible for Medicaid in those states, one of the reasons they've gotten so interested in social determinants is because now they're responsible for long-term services and supports and for mental health, and there's so many more manifested social determinants needs there. So literally that structural change in the way Medicaid is being run in states is creating a conversation in the policy and the payment world about, we don't have the resources, we're not tackling this appropriately, we're not screening right. And so I think there's another wave coming of just a recognition that there are much better ways, more systematic ways that we can help people and communities.
Let me draw this discussion to a close. Please join me in thanking Dean MacKenzie and Dr. DeSalvo.